Welcome everyone to yet another exciting day at the Muggles Potions Masterclass, your survival guide to pharmacy practice in Malaysia. This is where we deep dive into the topics that we face every day in the Malaysian hospitals. If you're a PRP or a pharmacist trying to survive the magic of a Malaysian hospital without getting hexed by the workload, you're in the right place. Let's get to work. So in part 1, we learned about what is NSTE-ACS, the diagnosis as well as the initial treatment. Now, let us deep dive into the pharmacotherapy in the management of non-ST elevation acute coronary syndrome.
Okay, now we're getting to the real meat of it, especially for all you pharmacy students out there. Let's talk about the core medications used in the hospital.
So, the absolute cornerstone of treatment is something called DAPT, or dual antiplatelet therapy. You've got aspirin, plus a second drug that hits the platelets from a different angle. These are your P2Y12 inhibitors. Now, you can start clopidogrel or ticagrelor right away, but then there's prasugrel. This one's different. You wait. You don't give it until after the patient has had an angiogram. Why? Because it's a potent drug with a higher bleeding risk, and the last thing you want is to give it to someone who might need emergency heart surgery.
Okay, so a big question is, how long do patients need to be on these two drugs? The standard answer is a full year, but it's not always that simple. Remember that bleeding score we talked about? This is where it comes into play. If a patient has a really high risk of bleeding, we might shorten that duration to just 3 or 6 months. It's all about tailoring it to the individual. All right, so on top of the two antiplatelet drugs, we also use anticoagulants. These guys, like heparin or fondaparinux, are attacking the problem from yet another angle. They're not targeting the platelets, they're going after the clotting cascade itself, the stuff that forms the fibrin glue that holds a clot together. They'll stay on one of these for their whole hospital stay.
Now, this next one might surprise you. Every single patient gets a high-dose statin, like atorvastatin 80 milligrams, right away. And you might be thinking, wait, isn't that for long-term cholesterol? Yes, but not just for that here. In this acute situation, statins act like a powerful anti-inflammatory. They go in and help to cool down that angry, inflamed plaque in the artery, making it more stable. It's a really cool effect.
Okay, last but not least, we have to help the heart out. It's overworked and starved of oxygen, so we give medications to reduce its workload. The go-to drugs here are beta blockers. By slowing the heart rate and reducing how hard it has to pump, they basically give the heart a chance to catch its breath. Of course, you've got to watch the heart rate and blood pressure like a hawk when you start these. All right, so the patient has made it through the scariest part in the hospital, but the journey is far from over. In fact, the real work is just beginning. So think about this. The patient's home, they've got a bag full of new prescriptions. What's the single most powerful thing they can do now to make sure this doesn't happen again?
Check out this number, 25%. That's the potential reduction in the risk of dying for patients who actually go through cardiac rehab. That is huge. It's a combination of supervised exercise, education, and support, and honestly, it's one of the most effective but sadly underused therapies we have.
And this is where you, as future pharmacists, become the MVP. That discharge counseling session is critical. You're not just handing over a bag of pills. You're making sure they understand why they're taking each one, what side effects to watch for, and what lifestyle changes they absolutely have to make. And crucially, you teach them the warning signs that mean call an ambulance right now.
So, at the end of the day, these guidelines are like a brilliant roadmap. They show us the best evidence-based path. But our job as clinicians is to be the expert navigators. We have to apply that map to the unique landscape of every single patient, their other health problems, their risks, their life. It's not about memorizing a protocol. It's about using this amazing framework to make smart, personalized decisions that truly make a difference.
Class dismissed. Remember, a great pharmacist doesn't just dispense, they protect. One wrong potion can change everything, so stay sharp out there on the wards. If this lesson helped you feel a little less like a muggle and more like a master, make sure to click the like button and subscribe to the channel. It helps me keep the laboratory running. See you at the next ward round.